What's up, everybody? We're going to be tonight looking at strategies for implementing digital workflows and digital planning. I think I know a lot of you. I've been involved in CE for a long time. It's really exciting for me to be back doing some things at the Pankey Institute. I think most people know I went through the continuum back in the early 90s. And from about 07 to 2020, I was the active clinical director at the Dawson Academy. And for a lot of us that are my age, it's important to sort of recognize that, way back, whether we heard Pete first or went to the Pankey Institute first, it was kind of almost like one organization. I went and heard Pete first and was in a study club with him. And I said, what's next? And he said, you got to go to Pankey. That's what I did. And so for me, the philosophical approach to dentistry, I picked up there. And I think a lot of my vision of what I wanted to do and what I wanted to become happened in Key Biscayne. And so it's exciting for me to be back. The way this started is Lee had asked me to speak at Masters Week last year, and I presented this topic, and it sort of elevated for me to now be going through all the curriculum again. My daughter's going through it as well, but I'm auditing all the classes. Actually go to E2 in a couple of weeks, and it's leading up to a hands-on course I'm doing next June. And I just want to make sure that anything that I'm presenting in the digital world is in complete alignment with what Pankey is teaching now. So I'm having a lot of fun, meeting all the faculty and participating. So before we get into the workflows, I do want to just reiterate that the most important skill set any dentist can develop is the ability to visualize precisely where they are going and develop efficient workflows to get them there, regardless of the complexity of the case. This generally does not happen in dental school, and it does take time, dedication, and commitment. And so what I, again, want to remind everybody is while we're going to be talking about digital things, patients are analog. So whether we're planning in an analog world or a digital world, remember that we still have to follow these principles of occlusion and principles of aesthetics, structural integrity, biology, all of that, and make it work inside the patient's mouth. And so as we think about that, it is critical. We've got goals for aesthetics, we've got goals for occlusion, we've got goals for biological health, and we've got goals for tooth-by-tooth structural integrity. When we're going to do a crown, when we're going to do an inlay, when we're going to go and do an onlay or a filling or take a tooth out or put an implant in or whatever we're going to do. These are the things, the fundamental things that we have to remember. And to me, it's why the Pankey Institute exists, because we don't tend to learn. We learn a lot about the bottom two in dental school, but not much about the top two in dental school. So whether it's Pankey, Dawson, Spear, Coy, Seattle Study Club, I've been involved with all of these in my career in order for me to develop sort of my way of figuring out where teeth go. And so whatever we have to do to visualize in our mind's eye precisely where we're going, so we can have these principles and goals, is really, really important. One of the things, quite frankly, that has gotten me so into digital is it scares the crap out of me that with where we stand right now, I see so many shortcuts happening in the digital world where a lot of these principles are being ignored. And I think it's incumbent upon ourselves to make sure that these principles of occlusion, aesthetics, biology, and structural integrity live in the digital world. So if we're going to plan that way, we don't change the principles. We may change the tools, but we don't change the principles. It's my daughter, Caitlin's so proud of her. She's getting ready to go to E3 next week. And so very, very excited for her, and seeing, again, the impact that the Institute is having on her is profound. It continues to crack me up because I have said a lot of the things to her over the couple of years she's been with me, but she comes back and says, well, Lee says this and Michelle says this, and I want to remind her that I've been saying that, but she tends to hear it more down in Key Biscayne, which is maybe as it should be, but she's doing great. And thanks again for the faculty that have been teaching her. I just really appreciate it. There's our crew. Caitlin's right next to me, and then we've got obviously an adopted son, and then Kristen and my beautiful wife, Kim. So when we start thinking about comprehensive case planning digitally, these are the sort of the million-dollar questions that I want to hit. Can data be gathered and case planning be completed more efficiently digitally than current analog methods? And again, I'm assuming that it's going to be as accurate. Can we solve aesthetic and functional problems digitally as well and more efficiently than current analog methods? And can a digital workflow allow for an interdisciplinary team to communicate better than current analog methods? So let's look at these primarily tonight and sort of go through them one by one. The first thing that I want to just kind of clarify or get an understanding is I like to break up the digital devices as data acquisition devices, output creation devices, and data manipulation, and I guess it would be really software. I think dentists, we're really familiar with cameras and scanners and digital x-rays and CBCT and face scanners and all the digital things that are available to us. It's sometimes a little overwhelming to figure out what we actually need. And we certainly understand output creation in terms of 3D printers and mills. Really, scanning and milling was probably the first digital entity with CEREC some 20 some years ago. But again, a lot of us are developing, getting 3D printers and doing some things in the office. I think people that are new to digital forget that software, whether you're dealing with something from 3Shape or Exocad, but really powerful software is the entity that allows us to have a virtual articulator and to do waxing and to do some of these really cool things where we can start to do all the things that we used to do in the analog world, just in the digital world, but just a lot more efficiently. And so I'm going to talk a lot about software tonight. And again, what you have to remember is it's not the software that comes with either the printer or the scanner. It's software that usually laboratories have. And that's where, you know, it starts to have an expense, and we'll talk a little bit about some of those numbers. And that's where you have to sort of look at time savings versus cost and things like that. So let's talk about the first. And data acquisition, just like anything, is extremely important. Scanning, digital photography has certainly been around a long time. Not everybody has CBCT, but it's become an important part of our practice for implants and certainly the TMD side of our practice. And in terms of scanning, I'll just say that with the clients that Lee Culp and I have now in our little group, our little study group, we've probably got 130, 140 people that we're sort of helping. And so we see everything. And what I'll say is we've got experience with CareStream. We've got a couple of iteros, but everybody that we're working with, whether it's the Medit, the Trios, the CareStream, the itero, you know, people are generally pretty happy with their scanners. And as I look at their data and what they can do for it, they all seem to be at a point where they scan well enough for us to be able to do pros and planning and do these different things. So if you're new to scanning, what I would just tell you is have the scanning companies bring it into your office. Think about what you're going to use it for. If you're really liking, you know, Invisalign and you do a lot of it, you know, a itero makes sense. If you're doing more pros, the Trios is great. The Medit, the price point, is also a great one. So that's just kind of what I would say. With all of them, there are certain things that we have to kind of think about as we're developing, getting a good scan. I love using these little obfuscates, the assistants do anyway, to kind of keep the lips out of the way. And if you watch a really good scanner, you're going to notice they're looking at this computer about 85% of the time, maybe 90% of the time, and very little in the mouth. Just with regards to some tips with crown and bridge that I would say is I was weaned on the 2-chord technique along the way. And, you know, the purpose of the 2-chord technique was to put in a little cord, a big cord on top of it, and just pull the top cord. And what we were trying to do with either polyvinyl or polyether is to get the impression material past that first chord, or past, I'm sorry, the margin, so that you could, you know, see when the lab was trimming the die, that they could see tooth structure apical to the margin. The thing that we have to remember with scanning is line of sight, and they're never going to see the vertical wall of the root. And you're going to see the margin from the top. And so what I've really learned, and what I really think about now, is just putting in one larger cord that I don't take out. and just make sure that it's pushing the tissue out enough that we can see. If you are scanning, make sure your lab is using not the STL file, but the PLY file, the PLY file, which is color, because if they're trimming your dies or marking your margins with a PLY file, tooth looks like tooth, the cord looks like cord, and tissue looks like tissue. It's very, very easy for them to see that. This is a great example, this molar that looks pretty good at first glance, but when you look at the mesial buccal of this molar, you can see there's a little area of the tooth that disappears behind that. And unless the scanner was able to kind of come to the distal and pick that margin up, that might be an example where that tissue is leaning forward over a little bit. So you might have to put a little bigger piece, or you might going to take your laser. But if you can't see it, if the tissue's over the margins, you're not going to be able to scan it. And so I've really found that it's putting in one larger cord has saved me a little bit of time. This is looking better. You know, that premolar looks pretty clean all the way around. So keep the site dry. That's critical. Use a single cord large enough to push the tissue away. Line of sight is the key. And don't take the cord out. Just leave the cord in. I also like to scrub the tooth with a little superoxol. That tends to kind of also push everything out and get it nice and clean. And then take your scan once it's dry. So again, just watching our assistant here, the opter gate's going in. She's going to go ahead and scan and spend most of her time looking at the screen rather than in the mouth. The other thing that I would just tell is most of the scanning companies are going to tell you that it's really about speed, and they train you just to get the teeth. And what I would say is, speed's great, but we want all the data. So have them scan another 30 or 40 seconds and get the whole palate. You want to get to the height of the vestibule. If you're going to be doing wax ups or, shell temps or different workflows that we can do, it becomes very, very important to make sure you get all the data. Just be as picky as you were when you were looking at your polyvinyls or your or your alginates from your assistants. Cone beam is also critical. Again, even if you don't have it, I do think this information becomes key. And as you'll see, one of the really cool things in the digital world is for us to be able to stack data sets, face scan with a CT, with the intraoral scans, and all these different things where we can kind of have layers where we look at. We can even put the articulator on top of all that. So being able to see these things and just view this as data sets becomes important. We use the Carestream 9600 CT, which does have a face scanner on it, which again allows for the stacking of the data sets within that, but we can also do it within 3Shapes itself. But I think we're pretty familiar looking at cone beam. Being able to look at things cross-sectionally becomes important. I like being able to look at the transverse on an ortho case to see the buccal plates there, just as an evaluation to make sure if we expand that we will have bone, not just pushing teeth or tipping teeth through the bone. We have the capacity certainly today to be able to mark an airway and to be able to measure that and see it three-dimensionally. That becomes exciting and cool. It's not the only thing we do, but it can give us sort of a red flag. And then, of course, looking at joints become important for us to be able to see from a sagittal and a frontal view what a good joint looks like, how it should be centered in the fossa, the cortical bone, the space. These are important things so that when we see an unhealthy joint, that we can start to really see a joint that's back in the fossa and lack of cortical bone. Looks like there's been a little moth in there eating the top of that condyle. This is somebody that just a quick glance at that, there's issues. And of course, we like to get all these things read by maxillofacial radiologists so that we can have a thorough diagnosis on the level of degeneration, whether it's active or inactive. I learned a lot from Bill Arnett years ago, spent a week with him, and then David Hatcher out there David is one of the ones that really founded Beam Readers. That's the site we use to have our CTs read. And again, just normal pathology. This is actually a patient that my daughter saw fairly new out of dental school and was looking at this PA. This patient was very symptomatic. It didn't really kind of seemed innocuous, but she came and asked, she said, do I think I should do a CT, like a little micro CT, and just compare? I said, sure, it's probably a good idea. Well, look at the same two teeth with this analysis, and then also look at first just what you're seeing on the x-ray and then the 3D rendering of it. I mean, this is what I'm talking about, our ability to see things. It's just not even the same case from looking at a PA versus what we can see three-dimensionally. So certainly data for analysis is very, very critical. Output devices, I'll just mention briefly, but certainly I would say most of the practices we are working with now, I'd say 65% of them are getting into 3D printing now and printing their own orthotics and their wax ups and shell temps and these type of things. And then we've got some practices that are milling. It's really interesting. Some of them started milling first, like they got into digital to be able to mill their crowns, whether they were doing it with Cerac or even with, with 3Shapes with like a roll and mill, and now expanding what they're doing with it as they start to use the software for planning and the virtual articulator and some of the stuff we're going to talk about tonight. We use the one on the left. There's the Vera Build. It was one of the Accurita printers that Whitmix private labeled. Whitmix has kind of gotten out of the digital space with regards to hardware now. They still have print resins, but they had that. They also had the Vera Echo, which we also have. But the hot one that we've got right now is this Sega printer, the middle one here, and this is the one a lot of labs have. Broad spectrum printer, fast, and really does a really nice job. So one on the left here, a little lower price point. This is a little higher price point, but broader spectrum and quicker. But I started with the lower price point just because I wanted to print a model, and I just wanted to print, some basic things. So look at them. Formlabs is good. Sprint Ray is good. There's several different ones out there at different price points. Pretty much what are we doing with printing? Right now, all our wax ups, our diagnostic models, if we need it, but we don't really print diagnostic models because they're all on a virtual articulator. The only thing we really print is after we've waxed or designed, and we'll talk about that. Certainly surgical guides, best orthotics I've ever made in my career, now coming from 3D printing designed in the Splint studio. And then the only other thing that I would say is now we're getting into shell temps and even temps that we're printing at the same time of the prep. So a lot of things are starting to change. Also doing our prototypes for our all-on-X cases. So that's exciting. So I want you to understand the concept of data stacking for a second, and to just pause this for 1 second. What I want you to understand when we talk about data stacking is to be able to stack two things on top of one another digitally. And if you've ever done a scan, put a scan body on an implant and scanned it, what the lab does is they have in the software something called a DME, which basically is a little virtual representation of the scan body. And what the lab does is they'll pick a couple of points. They'll pick a point on the scan body and a point on the DME they'll match these things up. And once you hit 3 points and align it, the data sets stack on top of one another. And once this DME is in there, that is basically how the computer now knows where this implant is in space. And so if we look at where you can see down the bottom there, that implant is attached now to the scan body that you did. So this is just a concept that I want you to understand, because we're going to come back on it a little bit later. Let's talk about software, which a lot of this conversation is going to be about. And again, when we're thinking about software, we use the 3Shape premium software. It's the software laboratories use. The base price of the 3Shape software is about $5,000 without the model builder. If you add the model builder, it goes up. But if you wanted to have the software that had the virtual articulator and the ability to wax, sort of, the Splint Studio, the 2D Smile Design Studio, it's all in there. And so that's sort of the base price. And then you pay an annual fee to keep it going. But that's kind of the price point that we're dealing with. But let's just look at this concept. And again, the first thing, you're just reminding you that there's really two types of software: the software that comes with the scanner, or perhaps an output device like a printer. And what I want you to think about it is, with scanning software, it replaces traditional impressions. That's what it does. The second type of software is the lab design software that replaces your model trimmer, your articulator, and waxer. And so for me, the biggest benefit of this is we took a lot of pride in our mounted models for years, and it was a couple-day process. My son worked in the office with us and, did all of that. And that 2-day process now we can do in about 10 minutes. And of course, it's always clean looking, right? Because there's no stone, it's all happening digitally. And that's what I'm going to show you. There's two basic kind of players right now: the 3Shape Premium or the 3Shape Premier, and the ExaCAD is another one. And I prefer the 3Shape primarily because of what we can do from an equilibration standpoint. But let me just show you Cornell mounting a case here. And the first thing that happens when you mount virtual models is you fill out an order form. This is lab software, so you have to put in a patient's name and fill out an order form. And we're not going to get into this in great detail, but this order form is important because this is where you're telling it what you are wanting to do. Once you've filled out the order form and say, yes, we're going to basically mount models, we grab the scans from the cloud. And again, this takes probably 30 or 40 seconds to grab the scans from the cloud. We're getting it from the iTero cloud. And then when the software opens up, the first thing that you see is this platform that appears before you. And your job is now to manipulate that maxillary cast so it lines up with that platform. And what I want you to think about with this platform is think about your DFA that you're learning at the Pankey Institute. The DFA is based on the Bonwell point, or the 100 millimeter dimension from the maxillary incisal edge to the condyle. So if you put this cast and line it up with the maxillary incisal edge, now when you bring in the mandibular model is going to appear in whatever relationship you scanned it. So if you scanned in CR, it's going to come in CR. If you scanned in MI, it's going to come in MI. But when you click on the articulator, it's there. Can we change the condylar path? Can we change the Bennett? We can change all of that. We even have ways to take some measurements in the back and protrusion to do like a protrusive record to customize the condylar guidance. So again, I would pay the $5,000 a year beyond whatever else we can do with it. This saves me so much time, and it is so accurate for me to do my planning. So but of course, we can do quite a bit more that will keep going. But that's how the basic mounting happens. Now, the one thing that we've got to think about, though, is that the software basically reads that platform, and it's going to want to line that maxilla up to it. And so if the maxilla is hanging in the patient's head nice and level, it's great. It's going to be fine on the mounting. But what if the maxilla is canted a little bit? We want it to be canted the same way on the articulator so that we can see that. And we'll get to that in a second. But right now, thinking about condylar guidance, or I'm sorry, the Bonwell point thing, is this good enough? Pankey's already gone down this road. I struggled this for years. I believe for a long time that an earbow was better than a DFA. And so I was still taking traditional face bows when I switched to this. But this article in 2015 in JPD helped me realize that the DFA and the earbow are both averages. They both are hanging around about a 9 to 10 millimeter, variable from where the actual condylar axis is. And we all know that earbows have worked great for years, and as does the DFA. So this helped me with that. My clinical experience has told me that I've found zero difference between the 100 millimeter average, the Bonwell point, from using the earbow average And so I think you guys have, I don't need to sell that to the Pankey Institute. This is, Lee has already taken us down that road. But so to be clear, what we're going to do is we're going to take this maxillary model. We're going to line it up with the incisal edge. That's going to place those incisal edges 100 millimeters from the condyle. The mandibular cast appears wherever you scan it. And I'm going to show you how we scan here in a second. The casts are going to be mounted accurately in minutes, and there's no wax. And so I really think a lot of the increased accuracy that I'm seeing with both Caitlin and myself, and Caitlin's learning this, but I do think when you're scanning in CR and capturing that data, I do think there's increased accuracy because there are a lot of ways your models can get off. Not that it doesn't work. I did it that way for 30 years. But if you have a little bleb in a cast or the wax distorts, there's just inaccuracies that we're always fighting against in the traditional analog way. And so I have much preferred going in this direction. So let's talk about this incisal plane. And again, if the maxilla is hanging flat like normal, it's going to work out for you. So how do we capture this incisal plane accurately? Well, we do it with a retracted photo. We can also do it with a face scan, but the retracted photo is a really simple way to do it. And we do it by data stacking. And that is, we're going to pick key points on the teeth. So we pick some points on the teeth, we pick some points on the photograph. And once that happens, that model or that scan will line up with the patient's face. And so once that articulator now goes in, because it's attached to the model, we can start to see how things line up. And what's interesting about this, and I'll show you in our example case, when we move the articulator, the model doesn't move. So the first thing, get the eyes level, and then go ahead and get the maxillary cast attached to the teeth, and then look at the articulator. If the articulator is off, we're just leveling the articulator, the top of the articulator, to whatever plane we want to align with. But we just find that however that maxilla is hanging the patient's head is now on the articulator in a good way. We really want to be accurate. We can take a CBCT, and this again is an extreme example of data stacking. The scan on the CBCT, the face scan on top of the CBCT. So we're seeing those various layers that we can peel back. And then if we want to line things up, we can take the articulator, and rather than following any DFA, we just put the condyle of the articulator right over the center of the condyle on the skull. That's about as accurate as you can get. All right, let's look at now scanning in centric. Certainly using a leaf gauge is a way to do it if you want to do it by manual manipulation and index it. I don't love this with scanning because, quite frankly, we did this primarily for wax, to have the room for wax to go in there. A leaf gauge is a much better way because we can scan just at the first point of contact. And the closer we're to the first point of contact, since we're not exactly on the hinge axis, the more accurate you're going to be. So just like you've learned at Pankey, you're going to add the leaves, keep adding until the teeth separate, forward, back, let them deprogram, then take the leaves away until you get that first point of contact, then add back, and you can have them squeeze just a little bit and then scan. I also really like the idea of scanning in CR and MI. So you can get a quick scan in MI and mount it as such. And then we can go and do our leaf gauge technique and go forward, back. You want to load test a little bit, have them squeeze, you can. But now, once you're comfortable with that, and maybe just barely the teeth are apart, then you can put the scan in there and capture CR. Pretty much that simple. So again, when we bring it into the three shapes, we're just using the CR bite, but I'll show you what we can do with the CR and MI, taking two scans in terms of patient education. Now, when I was first doing this, I was always comparing it back to my mounted models. with a face bow bite. We're printing our models at this point. And again, what I wanted you to see is the first point of contact. If we look at the model on the left, you see 3 basically dots, CR interferences, and amazingly in the scan, they're in the exact same place, even very similar shapes. So once you see this a couple times, you're like, okay, this is working out for us, and we can trust this data. In terms of digital waxing, we're not actually going to wax. We actually scale teeth. So we have about 100 different types of molds that we can choose from and bring them in, and we're scaling these teeth in to the desired. So we're still going to look at photographs. We're still figuring out where the teeth should be, but instead of there with a waxer, we can just do this a lot faster. So, you know, a case like this typically is going to take me, you know, maybe 20 minutes to be able to do a nice 8 or 10 unit wax up. From the aesthetic side, a little bit more if I've got some functional things, crowns or things where I'm working out, but it tends to go extremely fast. And again, with virtual articulation, we'll show you this with the example, but our ability to be able to move the cast and be able to see all the excursions and then print a model for us to be able to print is what we're after. You know, being able to dial in an occlusion, just like you would have marked an analog and read the dots, you can do those same things in a virtual environment. You can certainly work out your excursions and see things like if you look at the left first bicuspid, you see a working interference there. You see a balancing interference on the upper right first molar, no canine guidance on the left canine. And so just like you would in the analog world, if you go in there and start to adjust or reshape that area, that buccal slope of that lingual cusp, and if we go over and start hitting that lingual slope of the buccal cusp of the premolar and adjust that, and then go ahead and play again, notice we start to see the line develop on the canine. There's that little skip on the canine where we still see some working and balancing movements, and we're going to just adjust those on both sides until we start to see that solid canine start to come into play. Similarly, in a protrusive stroke, you know, if you've got lines on one tooth and you want more solid lines on the other, you can either add to the ridges of one tooth or you can take the other away, just like in the analog world. But what I like about the digital world is that the articulator can keep moving as you're adding and subtracting. You're not stopping and putting paper in there. So that does allow things to move a little bit quicker. But again, we have the capacity to see these things start to develop just like we did in our analog world. So just some of the lit review. If you want this from me, just email me. I've got the email on my last slide there. If you'd like to see some of the things that look at the accuracy of scanners. We also have some lit review on virtual articulation. The deviations are less than 100 microns, which is, again, very similar to what we see in the analog world. We'd all like to see this go down to 1, but remember, there really isn't anything where we're working on a 1 micron level. But I can be happy to share some of this data with you. So can data be gathered and case planning completed more efficiently digitally than current analog methods? There's no question about that. As long as we're working within sound principles, then I feel very, very confident about doing it. What worries me is people that don't understand occlusion, don't understand aesthetics, don't know where they're going, and they're just waxing teeth into space. We've got to use the same concepts, but just use this instrumentation properly. Can we solve aesthetic and functional problems digitally as well and more efficiently than current analog methods? So I wanted to share with you that when we go down this road now, there's kind of what I call 3 levels of this. There's the observer, there's the communicator, and then there's the designer. And when I look at this, the first one is when the doctor does not own the software, but they're working with a lab and they're communicating with them at a very high level through TeamViewer or something like this. The designer is when the dentist owns the software and pretty much does all the design. The middle one really interests me right now because this is the growing part of our group where the dentist or the dental office owns the design, but the team member masters the buttonology of the software while the dentist is over their shoulder communicating at key steps. I do think the dentist has to know enough to be able to grab the mouse and finish things, but this is where we're going now. Charity in our office is becoming a godsend, working with my son, the two of them kind of get the software and get it to a point that Caitlin and I can sit down and quickly finish things. So you have to kind of figure out where, what fits as you go. Let's look at Chrissy's case. It's just a fairly simple veneer case that I'm going to go through quickly. A typical case that you might see at the Institute. Wants her smile changed. She's got some sore muscles. She's got headaches. She's got a big slide that we'll see here in a minute. But the thing that really sort of drove her was that she didn't like her centrals. Centrals look big to her, when in reality, her centrals are a little square, but she kind of has small laterals. She also has some crowding on the bottom, has some splotchiness she doesn't like. So she'd like to have some aesthetics things done. She'd like to get rid of her headaches. Looking at her length, we can say that the length of her teeth, looking at rest and E, is pretty good. We look at her tip down smile and we see that these edges are back, probably retracted, small laterals, probably closed all the space, retracted her. It's probably why the lower incisors are crowding a little bit. Canines are in class 1, so that helps us. And she's pretty healthy. I do not like that lower left lateral. I don't like crowded teeth like that if I'm doing veneers, as it creates problems with protrusion. So we're going to get all this data and we're going to scan. And this is what I want you to see that's cool in iTero. You can't do this with Trios right now, but the iTero and the Medit, I think Carestream too, allows us to do a multi-bite. And with a multi-bite, we scan one in CR, one in MI, and then we can toggle through this bite. Leah's actually added this particular video to E1 because it shows you a nice example of how well, when we toggle between CR and MI in the digital world, how we can really see how the teeth interface with one another. Remember, if you want to see where facets, turn off the color and go to your STL, and you can see that facet. And what I find by scanning in CR and MI, that when I toggle between the two scans, patients really understand the importance of centric relation, that they are in fact rubbing their teeth in a way that they can't feel. This has helped us tremendously, very, very quickly help people understand the importance of centric relation and a good seated condylar position and a good balanced occlusion. It's pretty incredible. You can also even add the where the first point of contact is, and you can see it right there. And just can't argue it. So people out west that are trying to say that people don't use centric and you should just stick something between their teeth and let the jaw drift wherever it's going to drift, we believe in CR for a reason. People do function and go there. And if you can rub your teeth distally, you do not have anterior guidance. You do not posterior disclusion, and you do not have control of muscle activity. So we're going to go through this FACEAD method of looking at this patient. And our acronym FACEAD, the first F stands for FAB. This is kind of ruling out any sort of skeletal issues that we might have. We like looking at Arnett's true vertical line, and with Chrissy, she has a pretty normal balanced face. We also do her stop bang test to make sure that she doesn't have any airway issues, and she scores 1 in the stop bang. If you want to know more information about this, this is easy for you to Google. This is our screening tool as we look at patients' potential for airway problems. She didn't have any issues there. A stands for arch form, and we want to have a minimum of 36 to 39 from the OL groove. Again, width, also a lot for sort of being able to breathe properly through your nose. With Chrissy, it was narrow, 35 millimeters. So again, that gave us some thinking that expanding her and maybe opening up space on either side of the laterals could be a good thing to do. It'll allow me to straighten these lowers out. Edges, we're going to use our photography to figure out if we're making any changes vertically or horizontally to her teeth. And as I mentioned, the key photographs that we use, again, that's taught at Pankey, that rest, that E, that tip down smile, the profile smile, the retracted smile to see the lower incisal edges. We can certainly do some imaging as well. This is something that is also involved in the 3Shape software. You can even put some porcelain in there and have a look at it to look at proportions. But two-dimensional planning is going to be key to where we're going. We're going to look at stops. And one of the biggest things we can do in this world is our virtual equilibration. This is something I really wanted you to see. So again, in the analog world, when we close down an instrument, what we know is that it hits the first point of contact and stops. In the digital world, when we close down an instrument, the teeth will just pass through one another. And we can actually close these thin meshes down until we start to see the lower teeth actually come through the upper teeth. So watch as we're closing down as the lower buccal cuffs start coming through the upper teeth. And we're going to close this down until we just start to see the front teeth come in. At that point, we can now look and see how much is sticking through. And if you were going to equilibrate this patient, you'd have to remove all the gray. It's pretty much lopping off a whole cusp, which seems to be a lot. Now, we can even be more accurate than this if we want to know exactly what this is. We can close this down. And again, I'm going to close it a long way so you can get the gist of what we can do. Look at the lowers coming through, but we're going to bring it back to where they just barely come through in the front. But then we can use the slice tool, and the slice tool is really cool because we want to know how much it's sticking through, how much we'd have to cut away. We can actually measure that and see that the penetration from one to the other, how much we'd actually have to cut away to make CR and MI is 0.7 millimeters. And in my world, in a young patient, that's too much. So I'm thinking that if I'm going to be doing ortho anyway, why not intrude those teeth a little bit, which I have a pretty good luck doing with Invisalign. Now, if you want to transition to digital, this is an interesting little device that will allow us to mount quickly. This is a little basically thing that snaps on your articulator, whether it's a Stratus or a Mark III or a Mark 320 or any of these. But it allows us from 3Shapes to print models with the proper alignment. If you've scanned it centric, it's maintained, and it'll just snap on there without having to use stone. This is from a company called American Dental Technologies. So take a look at that, about $300. And if you just have a printer, you can print this pretty easily. This becomes an important step for us right now. Caitlin always goes this route when she's doing an equilibration. We can do a trial equilibration digitally. You just don't learn the brush strokes. So this is a time to go back to analog. I don't need to do it. I've equilibrated enough that I can see it digitally and go do it, but she still needs to be able to do those brush strokes, and certainly learned equilibration from equilibrating a lot of models. We're going to also develop anterior guidance and disclusion with a combination of some ortho, intrusion, equilibration, and restorative. So just looking at her plan is going to be to continuing the recare. We're going to do some Invisalign. We're going to do phase 2 records, then do our equilibration, then do our restorative work, and then do our final retainers. So here's where her Invisalign was. It was just 12 trays, and we ended up doing about a 6 or 7 tray alignment. So you can kind of see the expansion, see the spaces opening up on either side of the laterals. And when we look at Chrissy pre-ortho, post-ortho, can start seeing the width of her premolars. Also notice the size of her masters are shrinking. It's interesting, isn't it? As she gets off those interferences. And setting ourselves up now, nice straight lower incisors. And again, canine is still in class 1. And hopefully got some intrusion. So let's check it. This was my slide in CR, from CR to MI, pre-ortho, pretty big. If we look at this one, here's my slide post-ortho, still there, but very manageable. Yeah, right, that little slide. So now we're going to go ahead and go through this whole thing again. New photos. Again, her face airway bite is already good. We increased the size of her arch form through ortho. So that looks good. We fixed her lower incisal edges with orthodontics. Upper incisal edges we visualized first 2-dimensionally. And now we're going to start doing the waxing. And I'm going to go through this pretty quick. But we're going to be bringing in photos, bringing in pictures, of scans, filling out our order form, getting this case mounted like I showed you how Cornell did. Uh-oh. I'm locked up here. I don't want to do that. I think I hit an annotate button. Okay, there we go. All right, so now I'm going to go ahead and pick the teeth that I'm going to go ahead and work on. Also doing a light prep of the teeth. This happens kind of rapidly. And now I'll pick the teeth and go ahead and bring them in. And this is just fun. This is the stuff we'll be working on together if you come to the hands-on. So once those teeth arrive, we can start doing our design. Now, as I said, one of the things we want to make sure about is that our alignment's good. So we'll first center the eyes, and we're going to cut away the mouth, and then we're going to be picking our points on the teeth. We'll be bringing that in. We then go right to getting the articulator in there and then lining things up. And again, we want to make sure that that articulator, notice how the teeth aren't moving, but the articulator is. So we're just going to line that up so it's level with the eyes, and then we're going to call it a day. So get that nice and level. That last little bit. And we're good. Okay. We can now start taking things away and getting our design in. So this is where we'll just start scaling, getting the restorations designed the way that we would want. And then working out our stops and our guidance. So once we get this design in, then we're basically going to send this to model maker, model builder, and then we can start to print things. So whatever the design looked like on that computer, that anatomic form, we'll print, we'll wash, we'll cure. And what I want you to see is the detail of this that we really have today, which again is pretty impressive compared to what it was 4 years ago. The printers just didn't look clean. You couldn't really have deep embrasures or clean tissues. So however we do this now, we're still going to make the same prep guides. We're still going to make the same provisional matrices. We're still going to prep the same. Now everything's the same. It's back to analog. Still going to make beautiful temporaries. We still have to adjust them a little bit, but you can start to see the anatomic form of the provisionals from our prints come into the mouth quite nicely. And then as we start seeing the transformation from pre to post-ortho to now provisionals, now the provisionals become our primary way to communicate. Pack the tissue, we're going to have, of course, scanned our preps. But one of the really cool things is, we're still going to mark margins and do all the things that we would normally. But the big game changer for me in the digital world is the ability, again, to data stack, bring in a model of the provisional, find a couple of points to line up these models and do that data stacking. So now when you basically make the provisional model slightly translucent over the prep model, the lab can see exactly where they're going to build these edges. This is where patient communication or lab communication goes to another level, whether it's length or it's, occlusion, because it's all there. So you can, again, kind of see with restorations in there how the lab can just grow them right to the length of where our provisionals are. This is going to lend itself to a predictable result with our before and afters, and ultimately a good occlusion. So can we solve aesthetic and functional problems digitally as well and more efficiently than current analog methods? I absolutely think we can. And I think the further we go along with this, with the data stacking, it just keeps getting better and better. And watching Lee Culp do this and the way he thinks, I think, is driving a lot of this. In terms of communication between the lab and the interdisciplinary team, one of Lee's great points was that the digital dentistry with Reshape creates the perfect foundation for the fusion of technology, artistry, efficiency, and communication. And I do think communication is huge. We communicate primarily through TeamViewer. The benefit of TeamViewer is I can call into his computer and we can both use the mouse and have a high-level discussion. This is the software I'm using with the teams that I'm working with. We all know Zoom. The Zoom's great for showing things, but you can't share mouses. Splashtop is the software we use to be able to call into the office, so we don't have to bring the design computer home. And then a lot of these little videos that you're seeing tonight come from Camtasia, which is about a $200 software. But if you want to create little videos for your office to teach buttonology, that's a great way to go. What I want you to think about this in terms of implementation is there is this process that I'm noticing where we start with good data collection, the just kind of scanning. The next level is if you get excellent at scanning, if you get good data and you start communicating, sending that to a lab that has design software, and you use something like TeamViewer to communicate at a high level, to look at mountings and wax ups, that's sort of the next level. And then I see dentists buying the software, they start doing mounting and basic wax ups. The next thing that happens is they may develop get a printer, start printing their own devices, their own outputs. Some offices go on and get a mill, and I've seen a couple of offices go all the way where they have all this stuff and they even hire a full-time lab tech. And that's kind of what I'm seeing. I think another way to look at this, though, is, and we'll talk about it in a second, is a maybe a little more logical way to look at this in terms of implementation. I do think you need to get great hardware that you like to use. These are all good. iTero, CareStream, PreShape, Medit, cone beam. At what point do you bring that in? If you're doing a lot of the implants and TMD, you may want to think about it. I think printer is something that's a little bit later. Virtual articulation, if there was an order, I would go scanner, software, so you can start doing stuff, put the outputs to the lab to let them print things for you, then get a printer, maybe a mill later on. cone beam, you can do almost at any time if you're doing a lot of implants or TMD. But I do think in terms of making the transition over to digital, scanning and virtual articulation is pretty early. I like to think about this in this way, is rather than choosing it as a linear thing, kind of choose a lane. I see some of my clients, not a lot of them, but sticking with scanning and working with a lab. The middle one is where the vast majority of my clients are. They're good at scanning, but they bought the design software and they're in the process of printing. So they're kind of here. And then docs that want to start doing their own crown and bridge, go ahead and get a mill and a furnace and all that stuff, and then maybe even hire somebody. But I think that for a lot of sort of Pankey docs that are used to mounting models and used to doing a lot of their own orthotics, this middle area is a pretty desirable place to be. So as you set yourself up for success, start with scanning and gathering great data. Photos, x-rays, CBCT if you've got it, but just start with getting good scans. Secondarily, as I said, I think software is important, but make sure you take the time necessary for you and your team to learn to use it. That's why we created our little group, to be able to coach people and have videos that teach them how to do it. And I would say initially have laboratories print or mill your outputs. Just focus on design first. If you want to manufacture things in-house, then you can look at purchasing a printer or a mill. And then lastly, just involve your team early, let them master the buttonology while you establish and maintain the standard of the practice. I think that is a really important thing to do. But just dedicate the time. If you're going to get stuck down this rabbit hole, just know that you're going to have to block some time for it. It's a fun thing to do. And again, now we're at a point like in our practice where it just saves us so much time, and our outputs are just so much better than we could ever have done when I would sit there during an NFL game and wax my own stuff up. I did that 30 years, worked, but I find this to be better. This is the quote from Dr. Dawson that drives me. Pete said years ago that digital dentistry, in the absence of sound, occlusal, aesthetic, and restorative principles, will only allow a dentist to screw up mouths even faster. So just remember that patients are analog. The principles we learned at Pankey Institute are the foundational principles, whether working analog or digital. And because digital saves time, it's even more important that we hang our hats on these foundational principles of occlusion. It's my biggest and fear. It's what's driving me now. This is our mission statement. This is the little organization that Lee and I have. Our mission is to accelerate the transition of the global dental community to digital technologies and workflows while maintaining the sanctity of sound, aesthetic, occlusal, biologic, and structural principles. We'll do this through world-class teaching, coaching, and consulting experiences. We will increase the efficiency and predictability and quality of patient outcomes. So again, we do have online things that we do, a big robust online series of a library of videos, and we do some online webinars, and we do some online one-on-one coaching. That's all part of it. But I am excited that the only really live courses that we're going to do is with Pankey. So Pankey is our partner from that perspective. We are going to be doing the first one on June 13th through 15th next year. 3 days. They'll be limited to 20 docs, 10 computers, and we're going to go through all of this, all the mountings, designs, the splint studio, implant studio, the whole nine. So you'll get a really good feel for what these things will do. 3Shapes will be there, as also at SIGA. So you'll be able to see what their printers can do.